Stroke is one of those diseases that's actually, it's a horrible disease because you've got someone who can potentially be completely functional, fit, home, independent, and then within a matter of minutes, they're severely disabled from having part of their brain die. It's a very, very cruel disease because it robs you of that almost instantaneously. The main treatments are either medications to break up the blood clot or aspirating or sucking the blood clot out of the vessel. And in a certain time period, we can give medications, clot-busting drugs, but basically a really strong anticoagulant that will break up blood clots. But it's not necessarily the most effective treatment. And in cases where we can, we like to go up through the blood vessels, either through the wrist or the groin, float a catheter up to the brain, and actually just use an aspiration catheter and actually suck that blood clot out. Actually probably the most effective treatment in modern medicine these days. So when you have a stroke, part of the brain may die, but what you've got is brain around that, which is salvageable. And that's what we're doing, is going in and pulling out that clot so that we can reperfuse that area and salvage that part of the brain. For the clot busting drugs, they're much more down at the sort of 6-hour type periods. And that's a little bit variable. But in terms of the aspiration technique, we can go out beyond 24 hours. We've got people who have come in completely paralyzed down one side of the body, can't talk, and within a matter of 5 minutes after pulling that clot out, they're awake, talking, moving both sides of the body. And I think it's probably the most satisfying part of my job is clot retrieval, because you can just see that functional improvement within a matter of minutes. A stroke in a child is probably not all that different insofar as strokes really just refer to a lack of oxygen getting to the brain. It's really the actual way it occurs in a child. So in an adult, it's most commonly due to atrial fibrillation, where the heart beats in an abnormal way. A little clot forms in the heart and then flies up to the brain. Or they have a blockage in the carotid artery in the neck, and then a little bit of plaque breaks off. Children, it's usually a different mechanism. The most common is probably dissection of a blood vessel, where you get a split in a blood vessel after, say, trauma, or if they have a disease where they've got a weakness in that blood vessel, or having a hole in the heart, where they get a problem on the venous side of the body, and instead of being stopped by the lungs, it actually flops across to the other side and then goes up to the brain. So those are probably the two most common ones in children. Interestingly, children's blood vessels inside the head from about the age of 4 to 6 onwards are actually almost the same as adults in terms of sizes. So we might use slightly smaller catheters, but it's nothing that is specially made for children. They're just slightly smaller catheters to get up there. It's exactly the same procedure down to children. Up until recently, we would actually transfer them to the Royal Adelaide and do that there. But in the last 18 months or so, we've instituted a paediatric stroke protocol where they'll get their scanning, they'll go to sleep at the Children's Hospital. We do the procedure at the Children's Hospital in the angiogram suites there, and then they go to the intensive care afterwards. And then they can progress to rehabilitation from there. So there's no need to involve the adult side of things at all, which is great. We've actually recently had a girl about 14 or so who had a collapse and had a basilar artery occlusion. So the basilar artery is a large artery at the back of the brain that supplies your brainstem, and it's critical functions, things like breathing, consciousness, that kind of thing. And that clot had actually come through a hole in the heart and then progressed up there. So we ended up retrieving that clot with an aspiration catheter, and she actually went back to school within a week or so, which is fantastic, because having been left alone, that would have progressed to potentially locked-in syndrome, which is where you really can't move arms or legs, and essentially just you've got above about here. Or she might have progressed to death, which is obviously a terrible outcome as well. So we've now formalised the process in South Australia to make sure that when it happens, even though it's very rare, we've got a system in place that involves anaesthetics, intensive care, neurosurgery, neurology, radiology. Everyone's able to work, and we're shaving minutes off the time, because minutes matter. I think really the main sort of outcome for that is that everyone's working as a team, which is fantastic, and that's what takes time off. What you can think of is that there's the immediate pulling of the clot type situation. Once you've gone through that, you need to work out how do you prevent further cascades of damage. So the NRF has a whole bunch of research looking at ways to be neuroprotective, so prevent all those free radicals and oxidative damage to the brain. Work out our decompressive craniectomy, so when you've got brain swelling with that cytotoxic edema, is opening up the box and letting that brain swell. And there's a whole bunch of research, so preclinical and clinical research, which the NRF's funded, and they're funded for a number of years. There's several neurosurgeons who've also been funded through their PhDs as well in stroke research. Adam Wells, for instance, who's a very prominent stroke researcher at the Royal Adelaide, he's funded by the NRF, and they actually funded my PhD as well. So they've been there for quite a while doing that. Most people who are involved in this space are quite interested in the clinical side, but they're also interested in the research side. And having the NRF there as a funding body and a good collaborative tool for preclinical research, clinical research, hospital research is a fantastic resource to have for the state, and something I think we can be very proud of. There's a number of trials running at the Royal Adelaide. There's one using a large magnet to help pull a therapeutic molecule through blood vessels to help break down those clots, which we're doing at the moment. Certainly Professor Kleinig, who has previously been sponsored by the NRF, he is at the forefront of clinical trials up at the Royal Adelaide, along with a number of other neurologists. And that's part of the reason I really enjoy that part of the job, because there's radiology, neurosurgery, neurology, stroke physicians all involved in that one area. And it's a fantastic outcome for the patient. If your child develops focal neurology, and by that I mean if there's one side of the body not working, or if they take a strike to the neck with a ball, that kind of thing, and then they've got, decreased conscious level or something like that, I think getting them to hospital early and not just seeing if it gets better by itself is probably important. 9 times out of 10, there'll be nothing there. And even if we do a scan and we find nothing, well, that's fantastic. We don't need to do anything. I think people are obviously worried about wasting time, and I don't think that should be the right way at all. I think if you have any concerns, time is critical. Come, worst case we scan you and we find nothing, well, that's fantastic. Less work for me.